Welcome to the Thinking Stack.
Great to be here.
Today, we're really going to tackle a huge question, one that's incredibly human and, well, sparks a lot of intense debate.
Which is?
Do we have the right to end our own lives?
Wow. Okay. Yeah, that's a big one. It goes way beyond just the legal stuff, doesn't it?
Absolutely. It hits the core of personal control versus, society's role in protecting life.
And the nature of suffering, what dignity even means.
Exactly. So we want to unpack this carefully using our thinking stack approach, layer by layer: perception, prediction, action. Let's begin with layer one, cognitive cleanse. What's actually true? What's the factual situation on the ground right now, say 2024, 2025?
Okay, stripping away the assumptions, what does the data show?
Well, globally, the numbers were pretty significant. The Telegraph reported that over 30,000 people worldwide accessed legal euthanasia or assisted suicide in 2024.
30,000. That's not a small number. It suggests this isn't some fringe issue anymore.
Not at all. And look at specific places. Canada, for example. They reported over 13,000 MAiD deaths. That's medical assistance in dying back in 2022.
Okay, 13,000.
And get this, that was about 4% of all deaths in the country that year. That figure comes from the National Post, citing a Health Canada report.
4%. Wow. That really puts it in perspective. It's become, a noticeable part of how people die there.
It has, and it happened relatively quickly since legalization in 2016. It makes you ask, why such rapid uptake?
Good question. Is it just awareness, or does it point to something else, maybe gaps in palliative care?
Could be, and it's not just Canada. The Netherlands. The Guardian reported recently for 2025 estimates that euthanasia accounts for around 5% of all deaths there.
5%. Even higher. They've had legal euthanasia for longer, since 2002, right?
Exactly. So maybe that shows a potential long-term picture, a kind of normalization.
Perhaps. It suggests it becomes an integrated, though obviously still regulated, part of their end-of-life landscape.
Then there's Belgium. The World Federation of Right to Die Societies documented nearly 4,000 cases in 2024, 3,991 to be exact.
And how does that compare percentage-wise?
That worked out to about 3.6% of all deaths there. So still significant, even if slightly lower than the Netherlands or Canada.
And Belgium and the Netherlands, they're interesting because they've sometimes included unbearable psychological suffering, not just terminal illness under strict conditions, of course.
Right, which broadens the whole definition of suffering in this context. That's a key difference between jurisdictions.
Definitely. And the landscape keeps shifting, even in the UK, which has been more cautious.
People magazine reported that Parliament actually voted in favor of a limited assisted dying bill in 2024. It's not law yet, but it's a sign, isn't it?
It is a sign that the conversation is happening more widely, even in places with strong opposition historically.
In the U.S.
Well, Reuters mentioned in 2024, you've got 10 states plus D.C. that permit physician-assisted dying. Oregon was the early one, setting a precedent.
So it's a real patchwork in the states. Some allow it, others don't. Shows how divided the issue is.
Absolutely. Which makes it even more important to be clear about what we're actually talking about. The terminology matters, doesn't it?
Hugely. We need to distinguish between, say, euthanasia, where the doctor administers the medication.
Right, versus assisted suicide, where the patient takes the final action themselves with help.
And then there's VSED, voluntarily stopping eating and drinking.
Which is different again. And separate from the established right to refuse medical treatment, people sometimes lump them all together.
They do. Confusing these terms muddies the waters, ethically and legally. Refusing treatment is about autonomy over your own body, a long-held principle.
Whereas euthanasia and assisted suicide involve an active step to end life, raising different questions.
So let's tackle some myths while we're here. First, it's obviously not illegal everywhere, as the numbers show.
Clearly not. Another one is that it's only about physical pain.
Right. As you said, some places consider existential suffering this profound sense that life lacks meaning or dignity.
Under specific circumstances, yes. And what about depression?
That's a complex one. The misconception is that if someone is depressed, they automatically lack the capacity to make this decision.
But it's not that simple, is it? While clinical depression needs treatment, it doesn't necessarily negate capacity, especially if someone is facing an irreversible terminal illness and has been properly assessed.
Exactly. It's about distinguishing treatable conditions from a considered decision in the face of, well, inevitable decline. There are usually rigorous checks for capacity.
So, after looking at all these facts, what's the fundamental truth emerging here?
I think the core truth is we are already allowing death in various ways, right?
Hmm.
Refusing treatment, palliative sedation. The question isn't if death happens, but how, and under what circumstances we allow it to be actively chosen or facilitated.
That seems right. The debate is really about the manner and the conditions surrounding that final step.
Okay, so having laid out that factual baseline, let's move into layer 2, moral intelligence. This is the tough part, the ethical core.
The what is the right thing to do question, not just for the individual, but for society.
Yeah. And this is where we hit those major tensions. Autonomy versus the sanctity of life.
Mercy versus, well, some would say murder. Choice versus potential coercion. It's a minefield.
It really is. Thinking about autonomy, I'm reminded of John Stuart Mill, back in 1859.
On liberty.
Yeah. He said something like, the worth of a state in the long run is the worth of the individuals composing it.
No, so if the individual is paramount, where does that leave the right to self-determination at the very end?
That's the question. If individual will is key, does it extend to choosing death when life feels unbearable or undignified to them?
It's a strong argument for self-determination. If someone, clear-headed, decides their life no longer holds value for them, shouldn't they have the right to choose?
And then you have someone like Nietzsche, a bit more provocative.
What did he say? In Twilight of the Idols.
Something along the lines of, one should die proudly when it is no longer possible to live proudly.
So, linking the manner of death directly to dignity in life. Almost like maintaining control, maintaining that pride right to the end.
Yeah, framing dignity as a kind of personal sovereignty. If you feel you can no longer live with that pride, the choice of death becomes part of it.
That's a very individualistic take, focusing on personal meaning. But it runs right up against other deeply held views.
Absolutely, like the stance from, say, the Vatican. In Evangelium Vitae from 1995, they called euthanasia an offense against the dignity of the human person, a crime against life.
A completely different framework. Life is sacred, a gift, not ours to end intentionally, regardless of the circumstances.
So you have these two poles, individual autonomy and quality of life versus the inherent sanctity of life. How do they reconcile? Or can they?
That's the fundamental clash, isn't it? One side prioritizes the individual's experience and choice. The other prioritizes a universal value placed on life itself. It's hard to see a middle ground that satisfies both fully.
And thinking practically, what's the moral cost of denying this choice?
Well, you have to consider the person in agony, maybe terminal, whose pain isn't managed, or someone with a degenerative condition who fears total dependency, loss of self.
The suffering we might be forcing them to endure, is that compassionate?
That's the tough question. Does preserving life at all costs trump the alleviation of profound, unwanted suffering?
But then, the flip side, the moral risks of making it too available.
Exactly. The concerns about vulnerable people. Someone with treatable depression who sees this as an escape. An elderly person feeling like a burden, maybe subtly pressured.
Or someone in poverty thinking it's the only affordable option compared to long-term care costs. Those are terrifying possibilities.
They are, and they highlight the absolute need for safeguards. How do you protect against coercion or decisions made in despair while still respecting genuine, considered choices?
It feels like there's no perfect answer here. Any path has potential harms.
That's the difficult moral truth, I think. Action or inaction both carry costs. It's not something algorithms or simple rules can solve. It requires deep human judgment, empathy, looking at each specific situation.
Constant engagement, not just setting rules and walking away.
Precisely. We can't automate ethics in this space.
Okay, let's shift perspective again. Layer 3. Systemic foresight. What happens next? When these laws are in place, what are the longer-term, system-wide ripple effects?
Right. We need to look beyond the individual case and think about the whole system. What changes when assisted dying becomes a more established part of society?
Are we already seeing some of these effects?
I think we're starting to see potential unintended consequences emerge. You mentioned Canada earlier.
With MAiD, yes.
Well, the debate there about extending MAiD to those whose sole condition is mental illness, even though it's been deferred to 2027, shows how the initial boundaries can be pushed.
And the case in Belgium you mentioned, the young trauma survivor.
Exactly. Cases like that, reported in The Guardian and Washington Post, spark intense debate about whether the criteria are being interpreted more broadly than originally intended. It feeds into that slippery slope concern.
Is that slippery slope idea a fair concern, or is it sometimes used to shut down debate?
It's debated. Opponents worry that starting with narrow criteria inevitably leads to expansion. Proponents argue that careful regulation can prevent this. But the examples show that the boundaries are tested.
It definitely requires ongoing scrutiny. What other systemic risks pop up?
A big one is the potential for economic factors to creep in. You mentioned the New York Post piece discussing concerns
About insurance companies, yeah.
that assisted dying might, down the line, be seen as cheaper than long-term complex care. The worry is that financial pressures, maybe subtle, could influence choices or availability of care.
That's a chilling thought. That cost could become a factor in life and death decisions.
Deeply chilling. And related to that is the state of palliative care.
How so?
If palliative care is underfunded, inaccessible, or just not good enough,
Then people might feel like assisted dying is their only way out of suffering, even if they prefer good care.
exactly. It wouldn't be a truly free choice if the alternative high-quality support for living isn't actually available. The Guardian has also raised concerns about marginalized groups potentially being disproportionately affected, maybe having fewer real choices due to lack of support.
So the big picture risk is if we normalize death as a solution.
We might, maybe inadvertently, reduce the societal drive and investment needed to make life truly livable for people facing really difficult health challenges.
A potential shift away from care towards ending things.
That's the systemic foresight challenge, balancing the option with the imperative to support life.
Which leads us naturally, I think, to layer 4, embodied insight. Understanding the desire to end life. This isn't just intellectual, it's deeply felt, isn't it?
Absolutely. We have to move beyond just diagnoses and laws and try to grasp the lived experience of suffering.
And pain isn't just physical, is it?
Not at all. There's emotional pain, social isolation, that existential ache, the feeling of meaninglessness or being a burden. It's all intertwined.
Neuroscience backs this up,
Yes.
right? Chronic conditions changing the brain.
Yes, research, like some from Stanford Medicine around 2019, shows how chronic pain isn't just a signal. It can actually rewire neural pathways, impacting mood, perception, everything. Hopelessness can feel physically terminal.
And trauma.
Trauma, too, can profoundly distort how someone sees their present reality and their future possibilities. It can trap them in a state where escape feels impossible.
So when someone expresses this wish, it's crucial to ask why.
Yeah.
What's the real root?
Exactly. Are they speaking from a place of clarity or exhaustion? Do they feel heard, loved, supported? Or are they isolated, desperate? Our nervous system, our whole embodied state, deeply influences these huge decisions, often below conscious awareness.
It's about seeing the whole person, not just the illness or the request.
The totality of their experience. Which brings us to layer 5, human-centered design.
Meaning, if we're going to have systems for this, they have to account for how real people actually behave, right? Not just logic.
Precisely. We have to factor in fear, fatigue, culture, love, guilt, all the messy human stuff.
Because what counts as a good death isn't universal.
Not even close. It varies hugely. Think about cultural differences, individualism versus family focus,
Religious views sin versus compassionate release.
socioeconomic status dignity versus maybe seeing it as financial relief for the family. That Canadian data you mentioned earlier.
About Indigenous peoples accessing MAiD less often.
Yes, linked by the National Observer Canada to historical medical distrust. It shows how culture and history shape behavior around these options. It's not just abstract choice.
That's a really important point. Choices happen in context.
And human behavior isn't always rational in the way we might assume. Remember that study from the NEJM on Oregon?
About people requesting medication but not using it.
Yeah. A number of people who got the prescription never actually took it. Just knowing the option was there gave them a sense of control, of peace.
So the psychological impact of having the option is powerful in itself.
It seems so, which means any system built purely on rational actor models is likely to miss the mark, maybe lead to unintended outcomes.
It needs to be designed with deep empathy for human complexity.
Which flows right into layer 6, risk and resilience. This is high stakes. How do we plan for failure? How do we build in safeguards against mistakes and, frankly, moral regret?
Asking what if we're wrong about a specific case or the system itself.
Exactly. And we have to look at the edge cases, the difficult scenarios, because they test the system's integrity.
Like the teen euthanasia cases in Belgium and the Netherlands you mentioned.
Those raise huge questions about capacity, consent, parental influence. And reports, even if rare, of alleged non-consensual euthanasia are deeply alarming.
And that risk of financial incentives we discussed.
That New York Post discussion highlights a potential systemic vulnerability where ending life could become subtly prioritized over extending it for cost reasons. That needs guarding against.
So how do we build resilience? What are the non-negotiable safeguards?
Mandatory second opinions are crucial. Independent, expert assessment.
Not just a rubber stamp.
Definitely not. Also, meaningful waiting periods, time for reflection, for exploring alternatives, for changing one's mind.
Allowing space for doubt or a shift in perspective.
And, critically, making high-quality palliative care the accessible default. It shouldn't be an either between assisted dying and good palliative support. Palliative care should be the foundation.
These safeguards act as buffers against irreversible errors or potential abuses.
They have to. Each one is a vital layer of protection.
Okay, finally, layer 7, the execution engine. Moving from principles to practice. How do we actually build systems that are ethical, safe, and supportive?
This is about operationalizing dignity, making it real.
What are the key components?
Comprehensive training for doctors and healthcare teams is huge, not just procedural, but ethics, communication, grief support, trauma awareness.
So they can navigate these incredibly sensitive situations properly.
Yes. Clear, unambiguous legal frameworks are essential. No gray areas that allow for misuse.
Robust support structures need to be in place, too.
Absolutely. Easy access to therapy, counseling, palliative care specialists, spiritual support if desired, a whole network.
And tracking, monitoring.
Crucial. Transparent systems to monitor how the laws are being used, detect any problems or abuses early, and feed that data back into policy improvements. We need to learn as we go.
So it's not just pass the law and forget it.
Yeah.
It's an ongoing process of building and refining this ecosystem of care and oversight.
Exactly. Because true dignity isn't just about the moment of death, it's about supporting the living, well, right up until that moment. The ultimate goal should be to build systems where the decision to die is harder to exploit than it is to make freely and autonomously.
Making sure the focus stays on alleviating suffering and ensuring genuine choice.
That has to be the guiding principle.
Wow. We've really covered a lot of ground, from the facts on the ground globally.
Through the deep ethical tangles.
Potential future impacts, the personal experience of suffering.
How people actually behave, the risks involved.
And finally, how you might actually try to implement something this complex.
It's clear there are no simple yes or no answers to that original question, do we have the right to end our own lives?
It seems much more nuanced than that. Perhaps the right exists, but it comes with enormous responsibility.
Responsibility for the individual and maybe even more so for the society.
Maybe that right can only truly be considered legitimate when we, collectively, have done absolutely everything possible to make sure life itself hasn't failed the person first.
That implies a huge societal commitment, doesn't it? A commitment to tackling suffering in all its forms, physical, mental, social, existential.
To fostering real autonomy, not just paying lip service to it, by providing actual support, resources, compassion.
And building systems of care that genuinely uphold dignity throughout life, not just offering an escape route at the end.
It's a profound challenge for all of us.
It truly is.
Thank you for exploring this incredibly complex and sensitive topic today on The Thinking Stack.
Thank you. It's vital we keep having these difficult conversations.
We hope this exploration encourages everyone listening to continue contemplating these critical issues, recognizing the many layers involved in this deeply human question.